we were approached about seeing how we could help explore supporting other rare diseases. So Sydney and I met a couple years ago, and I feel like it's a match made in heaven, which I'm sure you feel the same way for in each of your own personal lives. But it's been just a wonderful collaboration together, and we've been doing just days of learning for GI cancer, and so it was a natural next step to see about creating a TGCT day of learning. So we're very thankful to have this be the inaugural event. This is, I think, the first time a group of TGCT patients and family members are gathered in one place, and it's so wonderful to be a part of that moment. So we're really excited about how the day is going to kick off. I just would like to thank our sponsors for this event, Is Tgcc, Decipher, and Synapse. And if Andre and Deirdre and Stephanie can please stand up, and let's give them a round of applause for coming here. Okay, wonderful. So I'm going to let Sydney now kick off from here.
So I'll just go over just briefly kind of what we're doing today. So you got the welcome from Sarah. I'll kick it off with the TGCT 101, and then we'll go right into Gary Schwartz, who's the Director or Chief of Oncology at Presbyterian Columbia Hospital here, and he'll cover all the drug regimens you could possibly imagine. We'll have a brief Q&A, and then we'll go into Dr. John Healy from MSK. Dr. Prince, like a hero, had to do emergency surgery and had to drop out last minute, actually at 6:15 this morning. So Healy's going to take over and encompass the rest of that talk, and if we have extra time, we'll do a panel discussion. And then we'll go for dinner, able to mingle. We'll have a patient support group. Many of us have probably waited quite a while to meet each other, so will be a great time. We'll have a closing statement, and we'll say our goodbyes. So to introduce the doctors kind of before they come, Dr. Gary Schwartz, who you'll hear from, he's a board-certified medical oncologist and internist. He's also the chief of Columbia University Medical's Division of Hematology and Oncology. He's actively involved in translational and clinical research. The lab, which he directs, focuses on the identification of new targeted agents for cancer therapies, especially the treatment of sarcoma and melanoma. His research has been supported by the NCI, or National Cancer Institute, as well as Lustgarten Foundation of Pancreatic Cancer, and the DOD for breast cancer research, and Byron Foundation, and the FDA. John Healy, who is my personal surgeon, so big fan of him. He's an orthopedic surgeon and the chief of orthopedic services at MSK. He specializes in caring for people with sarcoma and non-cancerous tumors of the bone and soft tissue, like us. He has a particular expertise in removing tumors while preserving the limbs. He has a special interest in treating children who have bone cancer, such as osteosarcoma and Ewing sarcoma. He's been at MSK for the dawn of time, since 1984, and he's approximately performs 260 surgeries each year. And his research involves understanding the molecular biology of sarcoma and developing new ways to deliver chemotherapy to tumors and improving the durability and function of joint replacements. He has invented 4 joint replacement systems and patented several methods of drug delivery. And so some of his lab members are actually here as well. So I'll get it kick-started with some TGCT 101. Again, the event is supported by our sponsors, so thank you. And so as Sarah kind of gave you a brief flavor of how we met, I wanted to give you a little bit more, since this is the first time I get an audience to talk about it. And so the LifeRock Group has a mission of improving resources for gastrointestinal stromal tumors, and their prognosis 20 years ago wasn't that great. Patients would present in the ER with bleeding and advanced side effects or symptoms, and people didn't know what the disease was. And so this group of patients came together once they got a diagnosis and really pillared a community of people that advanced the research, the treatment, and the prognosis for this disease. And so, very micro scale, we have our little Facebook groups where people go for similar things, to talk about the disease, to talk about how to get better treatments for the disease, and even to support each other through the disease. So what we found is Sarah, actually it was Sarah herself, came into the group and asked a key question. Would you change your diet for a drug to be more effective? And I was like, oh, that's an easy one. Let me answer that, as many of you have seen. And I answered very, very technically, very much that, well, the FDA regulates how you eat around drug regimens, and that's based off of absorption and toxicology of the drug, and ever since then, she was like, who is this person and how can we meet? So we made an interview or some phone call, some form of interaction, and it was love at first sight. They have the platform and the means to really blow up a disease in a way that benefits the patients. And that was what I was after. So what we did is we made Tgct Support, which is a program of the LifeRap Group. So with their resources, our collective effort, we started it in 2019, and we've done a lot since. So we have a little over 300 members now within our group. We have 244 members that are Tgct and 56 that are giant cell tumor of the bone. What many of us don't realize is giant cell tumors are kind of part of a collective disease. One is giant cell tumor of the bone, and then one is our disease. So I could not do one without helping the other. And so we went together to work with both of these patients. We have 6 support groups spanning from English, French, and German. We have 96 mentors within Tgct Support, and we have 21 mentors within the giant cell tumor group, many volunteers, and we just had a fundraiser that raised $25,000 thanks to Demi. So we're killing it. And we have many, many countries involved, including the US being the top, the UK, Australia, Canada, and Germany. So again, thank you, particularly Sarah, because without her, we would not have the platform, as well as the fundraising committee, which Virginia and Oscar and some of the amazing names you've all heard, as well as Yessie, were a part of making that ribbon, as well as part of our logo and our website. The PIs that are involved in treating this disease, the physicians, we have a medical advisory board now, so we can bring things to physicians and say, how do we make this better? As well as the sponsors and the donors, and most importantly, patients. Because without the disease, we would have none of this. So I'm going to go over now the biology of Tgct. Some of you have heard similar things, but I just want to make sure everyone's on the same page when we talk about the disease. And I am the director of Tgct programs as well as Tgct Support. Most importantly is the disclaimer. I am not a physician. I am a scientist. I work in oncology and metabolism with an experience in cancer research, and that nothing in this presentation should be regarded as medical advice or as a substitute for consulting with your doctor, even Healy or Gary. So we'll go over some of these topics. First, we'll start with what is Tgct. We'll go through a history of the naming, because it went from PBNS to Tgct, and a lot of people go, why? What is Tgct actually made of? What causes the disease? What is this so-called CSF1 we all hear about? With a little crash course in molecular biology, because I have to, can't help it. And then a history of targeted therapies, which Gary will take and run with and go through the rest of the therapies. So what is Tgct, or tenosynovial giant cell tumor? It's a benign, which is arguable, neoplasm of the unknown origin of the synovium, which is this layer or lining of the joint capsule, which houses the synovial fluid. The tendon sheath, which is this thin, soft tissue surrounding the tendons, mostly on your hands and your feet, as well as the bursa, which is a soft tissue sac that reduces friction and acts as a cushion, mostly in the knees. So you hear a lot of people talk about that. So we often get compared to cancer, right? We're seen at cancer centers, we're treated by sarcoma doctors, so what is the major differences? So Tgct, while to us is fast growing, it is not the same type of fast growing you would see in cancer. It is locally aggressive, affecting a single joint. It rarely metastasizes, so rare that it would be a case report. For it to go metastasize, meaning spreading anywhere, so lymph nodes, anything like that, we don't have. But it puts stress on your bones, your tissues, and your joints. What they share with cancer is that it can be fast growing. There are many of us who have experienced something that we would consider fast. So no one likes to be told it's not fast. It doesn't have distinct borders, particularly in the diffuse disease, where it can encapsulate a whole joint and be part of the full tissue. It also can affect healthy tissue and bone, like infiltrating into many of the bone and things that we see that causes damage. And it's also treated with chemo, which is a word I don't think is done justice, because the chemos we are on are called targeted therapies. So what we think of chemo is just a drug that kills everything. These are targeted to a specific protein. So largely, cancer is very systemically aggressive. It is a global disease that can spread to other parts of your body, where it often metastasizes. Sarcoma is particularly known for metastasizing to the lungs. It's life-threatening, and it dissolves and invades healthy tissue. So this name change, we see it all the time in the patient forums. Do I have PDNS? Do I have Tgct? Are these the same things? So in 2013, the World Health Organization took Tgct and encompassed a bunch of diseases, including, so it took PDNS, and it encapsulated that one. It took nodular synovitis, it took giant cell tumor of the tendon sheath, and it took tenosynovial and made it into one disease with two subtypes, localized disease and diffuse disease. You'll also, moving forward, possibly hear localized calls nodular synovitis or nodular disease. This is largely because biologically, all of our disease is localized to a joint. So pathologists didn't really like that term. So nodular means that it's encompassed in a sac. And so that word will be used interchangeably with what we know as localized. So what are the key differences? Under a microscope, these diseases look absolutely the same. So there are some key differences, mostly in how the disease presents itself and the behavior of the disease. Diffuse disease typically affects larger joints. 75 to 80% encompass the knee area. They do not have distinct boundaries, which is particularly the most important feature for why it's so aggressive. It does not have distinct boundaries, meaning that it can look like healthy tissue, and it can invade so much so that you can't tell the difference. It often is seen with multiple tumors, and it's much more aggressive strongly because of its lack of distinct boundaries. And because it's more aggressive, it does have higher recurrence, where it starts around 50% for a diffuse patient, and it can go up to 77% after surgery. For localized disease, it is considered more common in smaller joints. You'll see it more commonly in the hands and feet. It has distinct boundaries, which allows it to be like a tumor knapsack, where you can rip it out in one go, and that is why recurrence is so low. It used to be known that it was a smaller sized tumor, and that it was often a single tumor, and that made it less aggressive and easier to remove. In recent years, we have removed this like standard size. So you'll hear that, oh, if it's above 5 centimeters, it has to be diffuse. We got rid of that because that's not typically how it presents. You could have a single, well-defined tumor that's 6 centimeters and it is still localized. So we took out some of those non-descriptors. But luckily, 90% of the disease is still considered localized. Most patients do get diagnosed with a localized disease and move on with their life. As many of us in this room know that that is not the case always. And so while this disease affects 43% per million people, 39 per million of those are localized disease, and we're the lucky 4 per million that have the diffuse form. Tgct can arrive in the same cells in many different locations. There's even patients that have it in their spine. And so Tgct can occur around joints, tendon sheath, or the bursa, with the majority of them accompanying around the knee region. Hip and ankle coming in second, with toes and fingers more common in the localized form, and the shoulders and elbow being much less common. Sarah? So again, why did this name change? The naming was extremely inconsistent. As you saw, there were so many diseases you could find on your pathology report. You could find that you had nodular synovitis. You could find that you have giant cell tumor of the tendon sheath. These are all the same diseases, and that makes it extremely difficult for patients to find resources, as well as doctors to know how to treat the disease. And so I like my little sting. So sting in New York, or an Englishman in New York, is still an Englishman. So no matter where the disease is, it is still the same disease biologically. The word pigmented villanodule synovitis, the word synovitis does not encompass the true biology of the disease. Synovitis is a simple inflammation of a joint. As all of us experience, that is not the case. It is also unresponsive to steroids. So many of us have had cortisone shots, and they didn't do anything for a reason, because that's not a simple synovitis. So it has this neoplastic biology, which we'll talk about, which is that tumor origin. And because of this, it should be treated by a multidisciplinary care team at a cancer center. causes Tgct? None of us like to know it, but it occurs sporadically. We were not chosen for any reason. It is neither inherited nor passed down within families. Its prevalence among men and women is similar, with a slight female predilection noted specifically for the diffuse disease. Its onset is somewhere between 30 and 40 years of age, with younger people tending to be affected by the diffuse form. It strikes randomly. It is considered multifaceted, so there's components of it we still don't understand. But what we do know is that there is no environmental, geographical, occupational, dietary, or lifestyle cause of this disease. And if there were any major risk factors, we would know it. So there's a lot we don't know. So what do we actually know about this disease? Well, we know what it's made of. So our disease, Tgct, is a soft tissue tumor. Soft tissues all come from this same lineage, so this adipose. Okay, the adipose is fat, bone, tendons, the marrow, cartilage, muscle, they're all made from the same lineage, like a family tree. So our disease is from the same lineage. More specifically, it has synovicytes, which are responsible for the production of synovial fluid within that compartment of the joint. It's also responsible for the absorption of the joint cavity, as well as that blood synovial fluid exchange. Within the tumors, you'll also find fibroblasts and stromal cells. These are considered a connective tissue, and where the meat is that osteoplast-like multinucleated cells, which is a really fancy term for they have multiple centers, so that's multinucleated. So when you look under a microscope, you'll see multiple nuclei or surrounded centers, and this osteoplast. Osteoplast-like cells are a type of cell that dissolves bone. So when all of us have bone damage, it is these cells responsible for it, and accumulation of these cells results in this bone reabsorption and the destruction of the joint. So all of those are encompassed in our little tumors, as well as these white blood cells. And these white blood cells have an immune component called monocytes and macrophages. These are a type of that same lineage, the white blood cell lineage. So when we start to talk about cells, they all have their own function, and they may come from a similar family. So I can't go on any further without talking about how protein is made. So we're going to start talking about genes, which are DNA, and that's the code, that's the blueprint for all of your cell's protein. And the human genome encompasses many, 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 many genes that encode for many proteins, right? We're complex beings. And so the genome is a library, and different cells read different books. So muscle cells will make actin and myosin, which allows us to contract and move. Red blood cells will make hemoglobin, which allows oxygen to disperse from the body. Neurons make ion channels, which allow you guys to listen to me talk. And so all of this is a result of genes, which are wound up really tight into chromosomes. And so that weird looking thing over there is a chromosome. And so that chromosome, that DNA, acts as a blueprint. The RNA comes in and reads that blueprint and says, this is what needs to be made as a messenger. And the amount of that messenger means the amount that you're going to produce. And that makes protein. Our whole body works off of protein. Protein exchange, protein doing jobs, functioning. And so proteins they're made up of amino acids. There's 20 of them. Here's some of them: alanine, lysine. These are what your high school biology classes' nightmares were made of. And so these sequences come together, and they can be anywhere from about 100 to thousands in size. And they start to make these structures, and their structure is just as important as the sequence itself. And so how they function together is how our whole body works. And so Tgct cells, like the rest of our body, has its own DNA. And what we know about Tgct is that they're aneuploidy, which is a real fancy term for that they have different amounts of chromosomes. And so you'll see that we have chromosome 1 over here, chromosome 2, chromosome 3, and there's 2 of them, and they come together to make a single chromosome. If you want to get technical, they're each chromatids, so they come together to make a chromosome. But what you can see is chromosome 7, there's actually 3 of them, and that's called trisomy. They also, within Tgct, number 5 is also a 3. I did not go to the effort to make a 3rd one for this picture, but it has 3. We're uncertain on why. That is still going on in research. But what we do know about chromosome 7 and why we have that extra one is that confers a growth advantage to affected cells. So it's an advantage our little cells have. Patients will report, and I don't really need to tell you guys what you experience, but patients report 5.8 out of a 10 scale of pain typically. Swelling, range of motion limitations, popping, clicking, pitching. We all have heard those. Skin warmth, tenderness. These symptoms are all unspecific. If you go to a doctor, which you all probably have, they will tell you it's probably arthritis. You probably need to go to PT. It's not something specific that tips you off that you have a disease that's potentially rare. And so there's often a delay in 3 to 4 years based off these symptoms. But these symptoms also mimic other diseases. And you'll see with the biology in a minute here that matches the symptom differences as well. And so we have some differential diagnosis of synovial chondromatosis, which is a buildup of cartilage that causes tumors. Synovial sarcoma, which is any of you had that in your differential, probably scared the shit out of you. Sports injuries like labral tears or femoral acetabulum impingements or fibromas. And so, for some reason, oh, it's hidden. We're not going to hide that one. We're going to unhide it. Okay, so as I said, that our symptoms and our biology is similar to other diseases we've heard of. We've all heard of rheumatoid arthritis, right? We've heard of sarcoma as well. And so Tgct is squished somewhere in between. It has many symptoms that are similar. So you'll see within both rheumatoid arthritis and sarcoma and Tgct that you have joint swelling, some stiffness, joint damage. What you'll find a major difference between rheumatoid arthritis and Tgct is that in rheumatoid arthritis, or RA, it's an easier way to put it, it's polyarticular, which means it affects many joints. It's not a singular one, and therefore is an autoimmune disease which affects your whole body. Some other features you'll see with rheumatoid arthritis that you won't see with Tgct is a suppression of the immune response. So none of us are immune compromised. But some similarities are is that we have that pervasive joint swelling. And what we do have in common with RA is that third chromosome for the chromosome 7. So you'll start to see some trends here and why we experience the symptoms we do and the biology, but that does not mean they're the same disease. For sarcoma, you'll see that it's similarly very aggressive when it's in a single joint. However, a major difference between all cancer and our disease is that it spreads and it can be life-threatening. No tumor is good, but our disease is rarely life-threatening. Some other features is you have that osteoplast signaling, right? We just talked about that. Those are type of cells that dissolve bone. And so sarcoma is known for that as well. It's a cell that dissolves bone and causes damage. You also have those large cells. Tgct has that word giant cell for a reason. The cells are really big under a microscope. And you'll also see, again, the third chromosome for chromosome 7. So you see some similarities amongst all these diseases, but some major differences from Tgct are that we have joint bleeding, which can cause that hemosiderin deposits. If any of you have seen the pictures of your tumors, they're rusty colored. Hemosiderin is an iron storage compound, so it oxidizes and causes rust pretty much in the area of your tumor. And so that makes it very pretty under the rainbow colors of anywhere from brown to orange. You'll also see that we have that third chromosome for chromosome 7, but a major difference is this CSF1 translocation, and that's the major drug target. So what is this translocation? This translocation is an abnormal chromosome break in which one chromosome attaches another part to a separate chromosome. So if you can see chromosome 1, and it is actually chromosome 1 and chromosome 2, that swap ends. And that allows them to confer higher or overexpression of the single protein called CSF1. This chromosome abnormality is present in 2 to 16% of cells. So really a minority of cells, and that's why many of us are partial responders. So CSF1, it's a medium-sized protein at 552 amino acids. Surprisingly, this all means something to someone, where it starts with a methionine and it ends in a lysine, and that confers the structure of it, which winds itself up to make this structure right here. So that's actually a crystal structure of what CSF1 looks like. And so CSF1 binds to the CSF1 receptor that internalizes a signal within our cells, and that gives a response. That tells the tumors swell, pain, grow. And so what you find is that the TGCT cells that express more of this CSF1 have this pro-inflammatory multiplicative response. And so it takes tumor-promoting cells, like those white blood cells, and it interacts in a way that causes the tumor to grow. So if you stop that signal and you stop the growth, and often you even have some significant shrinkage, which you'll see. So what do we know about CSF1? I love my family trees, and in biology it's very similar. We have family trees of protein, and so this is what the human tyrosine kinase family tree looks like. And so you'll see CSF1 right over there, and KIT, which is a sibling, it's a sister gene, so they're right next to each other, which means they function similarly and they look similar. You see ABL as a distant cousin. They only see each other on weekend holidays. But what you find similarly in these family trees is that these proteins look similar, so drugs can target them similarly by accident. And so what we found in the treatment of chronic myeloid leukemia, which is a rare leukemia, it's a cancer of the blood, that these diseases look totally different from each other, right? Blood cancer doesn't sound anything similar whatsoever. But a mutation causing chronic myeloid leukemia is found in ABL, which is what you just saw as a distant cousin. And that was discovered in 1985. And so ABL is within that tyrosine kinase family you just saw, and so is CSF1. And so what we found was drugs that inhibit or shut down these tyrosine kinases are called tyrosine kinase inhibitors, and they may work similar for other diseases affected. So imatinib or Gleevec inhibits ABL specifically. And if anyone has been on imatinib, you're like, well, chronic myeloid leukemia is not what I have TGCT. And this is why. So TGCT therapy benefited strongly from chronic myeloid leukemia discovery. And we found that CSF1 KIT, like ABL, are tyrosine kinases, and there becomes the first generation of our drugs. So imatinib and nilotinib, which we pretty much rarely use nilotinib, but imatinib were all discovered for a different disease and not TGCT, but they work for TGCT because they inhibit this similar compound or similar protein. And so targeted therapies stop this back and forth talk between tumor-presenting cells or tumor-promoting cells and the TGCT itself. So that'll be a great segue for Dr. Schwartz when he comes and tells you more about the drugs and less on the biology. But at this point, I will take any questions. Yeah?
Sydney, I remember seeing, and you referenced this about there not being any metastases as it relates to TGCT, but I saw on our Facebook post there was a death. And so can you elaborate a little bit on that in terms of?
Yeah, I'm sure Dr. Healy can answer as well. I see him, but a lot of people with metastasis have malignant TGCT, which is a different, similar disease but not the same.
Thank you.
Those people have a life-threatening form of sarcoma. Dr. Healy.
Great.
Yeah, he'll definitely cover it. Yeah, definitely.
Do you ever run into anyone that has a sibling that has NF1?
Yeah, so NF1 does cause more tumors, particularly in other diseases, but not in TGCT that I've heard of.
Well, did you ever hear of, there's a doctor that correlates them together?
Yeah, correlation is like every scientist's worst word because correlation is not the same as causing. There's also people who correlate coffee drinking to longer lifespan. So under the right statistics, you can correlate a lot of things. There would be a large body of evidence that would have to prove as a causal thing. So it's something to keep an eye on, but not necessarily something I personally would be concerned of if you know someone with NF1 or NF2.
My daughter's who has PBMS, her twin sister has NF1.
Yeah, oh, they're identical, just out of curiosity. Yeah. It would be interesting. I think there's many interesting questions, but it's unlikely related.
They're hypothesis generated.
Yes.
At best.
Yes, very hypothesis generating. We have a lot of those in the group. You always hear, well, I have this autoimmune disease, a lot of MS. Is that related? Like, well, women are more likely to have autoimmune diseases as well. We're also more likely to complain to doctors when we have symptoms. It's probably a coincidence. But some of those coincidences are weird feeling. You feel a little too close.
Yeah.